So next patient is Cushing syndrome. 50-year-old patient has been referred to your clinic with a recent onset of hirsutism, weight gain, early easy bruising, and weakness in the arms. On examination, you see stria, round face, and a hump on the back. What is likely diagnosis? Cushing syndrome. What is Cushing syndrome? It is a sign and symptom that develop after the exposure to high levels of circulating glucocorticoids, cortisol, as a result of excessive adrenocorticotropin hormone production or autonomous adrenal production of cortisol. The clinical features include obesity, hirsutism, proximal muscle weakness, stria, bruising, hyperpigmentation, coagulopathy, increased incidence of bone fracture, and hypokalemia. What is pseudo-Cushing syndrome? Pseudo-Cushing syndrome is a group of conditions associated with the clinical and biochemical features of Cushing syndrome, but the hypercholesterolemia is usually secondary to the uncontrolled diabetes, alcoholism, obesity, and pregnancy. What are the causes of true Cushing syndrome? So true Cushing syndrome is either ACTH dependent or ACTH independent. So ACTH dependent mean hypothalamus pituitary adrenal axis is existed. So ACTH dependent mean pituitary is creating more ACTH, which is causing the adrenals to produce most glucocorticoids or cortisols. And second is there are certain tumors which secrete ectopic secretion ACTH, which can act on the adrenal to provide the steroid. So these are small cell lung cancer, carcinoid of the lung, or ACTH levels higher than the pituitary Cushing's. Causes are more pronounced. These ACTH dependent more produce hyperpigmentation, muscle weakness, and hypokalemia. And the one which are ACTH independent, so it's mean locally someone is producing like adrenal adenoma, ACTH suppressed by the negative feedback, adrenocortical carcinoma, and bilateral adrenal hyperplasia, and heterogenic long-term steroid use. How would you confirm the diagnosis in this patient? So first, confirm the Cushing syndrome. Ideally, at least 2 sets of the bloods should confirm 24 hours urinary cortisol level, number 1. Number 2, raised midnight cortisol level, that it will be raised due to the loss of diurnal rhythm. And then you should do the low dose dexamethasone test. This will decrease the morning cortisol in normal individual, but if it's a syndrome, it will be raised. Exploit the loss of negative feedback, and then establish the cause, that is elevated cortisol, ACTH dependent. ACTH if raised, then ACTH dependent. If low or 0, then ACTH independent. So how we can check the ACTH? High dose dexamethasone suppression test, and pituitary lesions retain some negative feedback and cortisol drops, and ectopic sources cortisol remains high. Follow blood test with the appropriate imaging studies. So blood test हो गए हैं जनाब, like cortisol हो गया, and low dose suppression भी होगी, high dose suppression भी होगी, और midnight cortisol level भी check कर लिया. If high ACTH, chest X-ray and MRI head to look for ectopic resources and pituitary adenomas. Inferior pituitary sinus sampling can also be performed. And if low ACTH means local, then CT MRI abdomen to look for adrenal lesions more than 4 cm in size, or household units, Hounsfield units more than 10 on CT, are suspicious for malignancy. Is there any role for nuclear medicine or functional imaging in the diagnosis workup for Cushing syndrome? Nuclear medicine functional imaging tests include the octreotide scan, FDG PET, and 68Ga somatostatin receptor PET CT improves the sensitivity of the conventional CT and MRI when hormone screening tumors in the Cushing syndrome prove difficult to detect. The blood tests confirm the diagnosis, and the CT and MR show a left adrenal adenoma. How will you treat the patient? The optimal treatment of the Cushing syndrome involves the identification and subsequent resection of the abnormal ACTH or cortisol producing tissue of the tumor. This applies to the lesions underlying Cushing disease, ectopic and adrenal adenoma lesions. In case of an adrenal adenoma, adrenectomy is the procedure of choice. For benign unilateral adenoma, minimally invasive approaches are available, like laparoscopic or retroperitoneoscopic approaches. This case should be discussed in multidisciplinary meeting where endocrinologists should be present, and all treatment options should be explained to the patient. Pre-op antibiotics and venous thromboembolism should be administered. There is a risk of fracture and hyperglycemia. And post-op steroid cover is needed until the normal adrenal function returns, and this can be checked by doing the ACTH stimulation test to assess the recovery of hypothalamic pituitary axis in patient with at least one intact adrenal glands post-operatively. Glucocorticoid replacement supplementation can be discontinued when the response to this test is normal. So, what is the role of bilateral adrenalectomy in the surgical management of Cushing syndrome? So, in patients with ACTH dependent Cushing syndrome who have had non curative surgery or for whom surgery was not possible, bilateral total adrenalectomy can be performed as a second line appropriate therapeutic option. In patients with ACTH independent Cushing syndrome caused by bilateral disease, bilateral subtotal adrenalectomy can be considered as the first line therapeutic approach. The limitation of bilateral adrenalectomy include the obvious necessity for lifelong steroid replacement therapy. In case of bilateral adrenalectomy, if the CT was normal and chest X-ray showed a small cell lung cancer, do you know how to control the symptoms? So miterapone, ketoconazole, and mitotane will reduce the circulating cortisol levels, and 50% of the patient will relieve from the symptom. Glucocorticoid receptor antagonists provide a different mechanism of action to reduce the cortisol action. Mifepristone has been approved for the treatment of hyperglycemia in the patient with Cushing syndrome. Finish.